I'm going to talk to you all about a vision for the future. Imagine that any of us, go to our doctors, our clinicians, physicians, and even before you walk in there, your doctor has had a chance to evaluate every possible way in which they want to take care of you, in which they want to treat you. They can do this using your virtual self. So not you, but a digital representation of you. What does that mean? A virtual computational model that looks like you, feels like you, behaves exactly like you. If you are going to develop a fever, that model is going to develop that fever. If you are going to respond to a certain kind of treatment, that model is going to respond to that treatment. So even before you have gone into a clinic, your doctor has the ability to evaluate all of these different treatments on your virtual self and come to you with the best one or two options. And then the conversation focuses on, let's see which one we can really make work for you. It's not a scenario where statistics show that for your type of cancer, this is the best outcome. Well, yes, statistics are important, but I care about what's happening to me, not to all of the others who are in that group. Imagine being able to do that. That virtual self is a digital twin. Think of a digital twin almost like a Google Maps for the human body. You've all seen Google Maps, right? You can see the Earth, you can zoom in, you can look at buildings, you can, if you're lucky, you'll find some of your friends in an awkward pose on Google Streets as the car was passing by. Think about that analogy for the human body, where you can model the whole body, you can zoom into organs, you can dive even deeper, look at DNA, and even deeper, look at the chromatin structure. These are things that make you human. We cannot model this in a generic manner. We have to model what makes each individual independent. But of course, there's a lot of modeling. That's not all we want to do. The vision is to have a digital twin for every single person. Not for the privileged few, not for high-income countries, but for every single person. Okay. Now what I'm talking about is not just, it's not science fiction. This is something that exists today. What you see on the screen is a digital phantom that comes from Duke University. It's a group I've worked with for many years, initially when I was at Duke and now as through collaborations. This is called the XCAT phantom, the extended cardiac torso phantom. You have a bank of phantom templates where if I have a patient walking in, I can pick whichever of these phantoms looks closest to that individual. And then, if I have a CT scan, I have some sort of imaging from that patient, I can identify what that individual's organs look like. Then I can morph my XCAT phantom so it exactly matches the patient that I want to. I can then model, I can then put in physiology parameters, the patient's breathing rate, motion, how does your body move, blood flow, respiratory behavior. So now you are making that person you're making that phantom a more accurate representation of the patient that you want to treat. What do you do next? That's a lot of modeling, a lot of computation that's involved. Having a digital twin alone is not the answer to our problems, right? You need a digital twin. You also need a computing platform that's going to let you probe that digital twin. You want to be able to have a platform, infrastructure, where you can treat that digital twin, you will get the outcomes you want, and you can keep iterating. You can customize the treatment to each specific patient. At Oak Ridge, we've been working exactly on that. We are fortunate at Oak Ridge National Labs to have one of the world's top supercomputers. It's a world-class machine with almost 9,500 CPUs and 37,000 GPUs. So we do have a fair amount of luxury in creating these patterns. Now, don't get me wrong. I don't expect that every single user of these digital twins is expected to have computing like that. That's not realistic, right? We are using this type of computing power to build the capability. And then you accelerate. This is where you bring in AI, you bring in speed-up methods. You develop this platform in a way that it can be run on a modest GPU. You don't need to do all of the calculations every single time. You work out which ones can be approximated and which ones are critical to evaluate that particular treatment. That is the future that I envision. Let me show you a few examples of what we have done using these digital twins at Oak Ridge currently. The first, let's talk about modeling tumor growth. What I'm showing on the screen in the figure that's on your left, this is a representation of a tumor. Imagine that the green are all healthy cells. They can be healthy breast cells or liver or whatever else. Red is cancerous tumor. And blue is a laminin enclosure that is surrounding your red cancerous cells. Now, let's say we treat that tumor using something, external beam irradiation or radiopharmaceutical treatment or something. Some of those red cancer cells will die. They will be replaced by the black, which is basically nothing, but not all. That is why we provide cancer treatment in fractions, right? If you stopped after that first treatment, the cells that did not die, the cells that have not been killed, will continue to grow and your cancer will expand. That is what you see in the figure on the right. So this is a simplistic representation of how cancer will grow in the body. And what we do with this? Now, first of all, if you want this to be a breast tumor line, or you want this to be a liver cancer cell or something else, you need to model the parameters that define that particular cancer cell. So we need to have the chromatin backing structure. You need to know the anatomy, the morphology of the tumor, of the cell, and all of that. Then, if you embed this representation into an XCAD phantom and then treat it, you can do something like this. What I'm showing on the screen now is four representative scenarios of how this patient could be treated or not. I'll walk you through all of them. Look at the red curve first. The red is no treatment. The patient developed cancer and it just continued to grow without being checked whatsoever. So you see that the cancer continues to grow and eventually the cancer takes up the entire volume of what we have defined as that volume. Now think about the blue curve. This would represent a patient who was diagnosed late, at a later stage of cancer. So we need to go in with a more aggressive treatment, kill as much of the tissue as possible. Well, if that patient got aggressive treatment, it worked. Look how much the cancer shrank in size. But then if you do nothing, it's going to again continue to grow and you will see that slope, that peak going up. Third scenario is my green curve. This is a patient who was fortunately diagnosed early, and so we didn't have to be aggressive with the initial treatment. We did that, but for whatever reason, additional treatment was not possible, and so they stopped. What happens now? Your tumors continue to grow, and the end result is almost as if they were not treated at all. The fourth scenario is the orange curve, where now we are delivering a fractionated treatment. Consistent radiotherapy at different time points. What you see over there is not only does the tumor shrink at each time point as you expect, but at the end, the curve has flattened out. Now, I'm not claiming that these are the ways in which we should treat patients. We absolutely should not do any of the first three. It is a representation to show you that we can explore what happens in many of these different scenarios. And you can do all that digitally. A different application, if you think about radiopharmaceutical treatments, this is a hot emerging area, especially with new isotopes coming into play, actinium and alpha emitters and other things that hold a lot of promise in treating tumors. This is where you inject a radioisotope into the body, it circulates through your body, it gets selectively absorbed by the tumor, and you have essentially delivered radiation directly to the tumor source. It's a big one. We have modeled this. You model the organs, you model the vasculature system, you model the injection into the patient, how the blood flows through the body. Does anyone have a solution to this? How many injections are there? We model all of these factors. We model different isotopes going into different parts of the body. We model the uptake, the biological clearance, and essentially how much of that isotope is going to sit not only in your tumor, but in other parts of the body that you might not want to actually locate. When you do that, you can generate these dose maps. Where is the tumor going? Where is the isotope going? How much radiation is it delivering to different parts of the body? The image that you see on the left is from what's called an extravasation event. Essentially what happens is when a patient is receiving the radioisotope being injected through a vein, sometimes because of a mishap, the needle goes right through the vein, comes out on the other side, and the entire bolus of the pharmaceutical is injected in the arm. Very unfortunate when that happens because you cannot suck it back out. You just have to tell the patient you just give them time. You're going to let your body cool until all of that pharmaceutical goes out. So we just try to move the arm away, try not to keep it close to the body. But what happens is that it's not a good scenario. How do we model what the impact in that case is going to be? So we can do that. That's the extravasation scenario you're seeing here. But even then, if you didn't have extravasation, you see different radiation concentrations in the kidney, in the liver. The bladder would generally light up because the bladder is where all of this radiation eventually collects before it is excreted from the body. And using these models, you can now measure, you can calculate how many DNA strand breaks were created by that particular radioisotope. You can even differentiate single strand breaks versus double strand breaks. Why? Single strand breaks are actually fairly easier for the body to repair, whereas double strand breaks, they are the ones that are truly risky. They're the ones that cause a lot of damage and downstream radiation risk. These simulation models give you the ability to evaluate those.
I'm going to try to attract you a little more.
Nice.
Let's see if it works.
If only they used logic. I'm just going to think that I smell sweet. Take that as a win. You can use these models to evaluate different isotopes, different organ doses, in fact, tumor outcomes. How much damage have you created? How much repair is induced? And what will be the outcome of that specific patient? We also want to go not only to radiation domain, but also chemotherapy. And to do that, you need to model the interactions between molecules and cells, whether you are targeting a certain receptor or a protein or some other pathway in the body. What I'm showing you over there is a yellow calcium ion that is trying to make its way through a cell membrane that is all lipids. It takes an immense amount of calculations to do this. Typically, to model about a nanosecond of activity in the human body, it would take days of computing time. And that's simply not realistic if you want to integrate that into a digital twin of every single human. So the goal here is you model these interactions, you evaluate them, and then you train AI models to speed these up. Once you do that, not only can you increase the time durations that you model in the body, for example, we're not looking at what happens over a nanosecond, but now you're looking at what happens over minutes, which is more realistic. But also, you are able to model this within a matter of minutes or hours instead of days or weeks. We have also just recently completed a synthetic data generation study where for the first time we took a bank of these XCAD phantoms and generated 10,000 CT scans. 10,000 abdominal CT scans from adult patients, pediatric patients, covering lung lesions, liver lesions, and a few other cases. In many scenarios over here, we could take the same patient and scan them repeatedly. What happens if you move the patient a little bit and scan them again? You can't do that in a real study, right? There would be ethical concerns. In a digital environment, our phantoms don't complain, they don't even have to comply. And so we have this. Now imagine using a data set like this where you have 10,000 image stacks with fully known ground truth. You can use that to train AI models, you can use that to evaluate CD protocols, you can use that to evaluate differences between obese patients versus skinny patients or pediatrics versus adults. There is so much possibility made possible, enabled by the existence of this digital twin platform. So where do we go next? If we can advance the slide. We have currently accomplished a fair bit. We have these digital twins, we have the anatomy, we have the physiology, we are working on the biology. To truly extend these digital twins into the molecular domain, you need to tackle them at every scale. At the whole body, you need CT scans, you need MR scans, ultrasound, any form of whole body imaging to analyze effects that apply at the macroscopic scale. How do we breathe? How do our organs move? What's happening in the body when a tumor starts to grow? Is it pushing one way or another way? That alone is not enough. We need to know how is the tumor behaving in a multicellular environment. It means how are all these cells coming together and leading to cancer growth or cancer death? Are they signaling each other? How would your tumor grow if it were left unchecked? What are the diffusion parameters, the diffusion kinetics that are going to govern how a certain molecule makes its way to your cancer, to your tumor, to that particular pathway that it's trying to target? And even deeper, the thermodynamics, the kinetics of how to make all this possible. It requires imaging at each of these scales comprehensively. That is what we need to come together to do. If we do that, we will have a digital twin for everyone. That is what we want. A digital twin not just for the privileged few, but for everyone. A digital twin that can enable physicians to customize their care for you even before they have actually seen it. Now, make no mistake, we're not there yet. There are many questions that need to be answered before we can do this. Hubert gave a great talk yesterday where he talked about different aspects of AI. He talked about ethics. He talked about explainability, trustability. All of that applies here. If I build a digital twin of you, who owns it? You or me? If I'm a nefarious agent who has been able to build a digital twin, what all could I do with it? How much error are we willing to tolerate in these digital twins when it comes to treatment? All of these questions have to be evaluated carefully before we can truly start integrating digital twins into our mainstream treatment. But that is what we all need to come together to do. So let's build that future.
The question that I had is, you've shown these different data with the different doses of radiotherapy. For a fact, I've done studies where I've shown that giving fractionated therapy is advantageous because it activates the anti-tumor immunity. Is that something that has been studied in your study? Have you looked at the anti-tumor immunity? My second question is, you've shown that the software is capable to see calcium, and we know one of the immunological signals is when reticulin release the calcium for cancer cells. Is that something that is feasible through your software to kind of live assessing immune response, anti-tumor immune response using this software with different radiotherapy doses? And my last question to global partnership was like one of the things, because I'm working with the Gabonese government, and what we're trying to implement is workforce training. Like you just mentioned, there are not many people. And for a fact, here in the state of Massachusetts, I'm part of a program that trains the next generation of biotech entrepreneurs. And what we do, we work with biotech companies that sponsor co-op or accelerator program for the mobility of the students. Is that something that is envisioned globally, where like different countries can collaborate and maybe industry stakeholder can contribute, not necessarily to provide the co-op, but to kind of provide mobility of students coming into an institution from one country into another to get training on certain machines? So that would be my questions. Thank you.
Right. I'll answer the first two questions. The first question was about immune responses induced in cells. Absolutely, that is something that we care about modeling. We have modeled that into the simulation. However, the real question is how much of an immune response should you model in response to a certain type of treatment with a certain cell or a cell line. So we have all of the calculation parameters built in there. What we really need is guidance from the medical community on what should be modeled. This is a simulation, right? It isn't magically making up answers for you. It is calculating things that are extremely difficult otherwise. It is simplifying the calculations and coming up with an answer based on information that it is provided. So yes, we have modeled these factors. However, we need to make sure that the value provided to the factor at the time the simulation is being run is correct. And same thing, in fact, with the calcium ions. It's simply about modeling specific pathways. If we have modeled a pathway in which calcium ions are being injected, emitted, and tracked, we can do that. One of the things that we have done is evaluated the presence of free radicals in response to treatments. So yes, we have done that, but again, the same point comes in. I don't know yet how much free radical concentration you would start to see if I treated patient A versus B versus C.
I can try to address your second question, which is about training and coordination. So I think that's something that maybe can come out of this, because for us, we do a lot of work in navigation, and now what we're trying to do is coordinate those efforts, because they're happening in multiple different places, they're different training curricula, trying to set some standard consensus so that we can move forward with one and share. So I think that's the thing, is that there's so many different training programs that are happening, lots of twinning that's happening. How can we think about, and there's lots of different training curricula, we as an organization have been thinking about the non-oncologists, because there's lots of task shifting happening in LMSCs, and how do we develop digital training curriculum together for those professionals. But again, I think there's so many programs happening. Can we leverage technology to be able to even understand who's doing what training curriculums are happening? Can we develop something together, coordinate? So, again, I think that's a question that I'm hoping technology can help us answer. I don't know if you want to add to that or others.
Thank you.
Right. Oh, yeah.
Hello, I just have I did finish with what you had. I just have another question. I don't want to.
Yeah, and please introduce yourself also.
My name is Bilinga Tendwa from South Africa, and I want to ask Dr. Kapadia about. I have a question concerning enhanced sampling and molecular dynamic. This is a topic that is very close to my heart, because very passionate about drug discovery and drug repurposing. So I wanted to ask, in your molecular dynamic simulation, have you looked at drugs like cancer drugs and how they affect the body, and how mutation will affect those drugs in terms of metabolism, and how you could actually bypass those mutations, maybe by drug repurposing, or discovering other drugs that could enhance the work of the drugs that are being used at the moment. And due to mutation, they cannot work properly.
One of the challenges with the drug discovery field is the speed of computing. It takes a long time to evaluate all of these possible molecules and how they will interact with the body. One of the things that we are doing, I didn't include that in the presentation here, we are developing a GPU accelerated platform that will let you do exactly what you said. We are testing that in the context of cisplatin interacting with specific receptors. So that is something that's underway. And you're absolutely right about the applications. Once you have that, you can test all of the pathways with which a drug will interact with a certain target. Yes, we have the ability to model the mutations. We would simply model a different target. And then you can evaluate what other molecules are possible that can then target that particular receptor. More importantly, this platform that I showed you, it doesn't tell you only what happens once you get your molecule to the target. It will also let you evaluate how do you get it there. So in that sense, it is a more comprehensive, a more holistic simulation of the human body.
Great, thank you so much. I'm going to have Dr. Odin join us. He gave some really inspiring and also very humorous remarks at dinner last night. So
thank you. Thank you
very
much.
With the Oncology Club of Bangladesh as well. So please introduce yourself and then.
Good morning, everyone. May you allow me to use my very important hat now. My name is Brian Chitsonge. I serve as the Pan-African Parliament, which is the legislative body of the African Union Food Security Ambassador for the continent. I just want to say thank you so much for making the tweet very simple. And I think it's something that we should actually pitch it to the heads of state. If they understand it the way you've made it, I'm sure all of them, they'll understand. And you simplified it to a point that they will all understand it. And that way they can allocate a budget for what's needed. Without their buy-in, we can sit and we can have as many symposiums, many summits, many everything. There's no point. Because most of the time is lack of understanding. I sit with a lot of them and they do not understand. You even talk about simple things, they preach about climate change, carbon exchanges, carbon sink, carbon sequestration, and they're like, what does that mean on the side, you see? Because they don't understand, but the more they understand it, the better. So I think in my capacity as your ambassador, I'm going to see how we can actually get it to the heads of state, whether get them at the African Union where they're all together, or visit them country by country so that we can get them to understand, because the minute you get one to understand, they can take it to the African Union and then discuss it amongst themselves, because this is amazing. I mean, this is technology at its best. Let them understand it. Thank you so much. Very informative sessions. Thank you, GHC, for putting this together. Thank you.
Well, thank you for that.
And I think we can all say that we're all at the ready to do what you just said. If any of us have the opportunity to help with that process, it'll go a very long way. We're all ready to get on planes and do what is needed. Thank you.
Yeah, and I think the Rewire framework is perfect, right? It's a perfect example, but yeah, let's talk more. I think that's great. Please.
Just a question to thank you so much for your speech. But I don't know, in my country, in the first time, Asian use a traditional medicine. I know in the traditional medicine we have substance, we can clean free radicals. I don't know what your experience. So maybe the future ways again to have solution against cancer. Traditional medicine and cancer in Africa.
Potentially. Now I can't. My background is in biomedical engineering and physics and computer science, so I come at the medical field from that perspective. My goal over here is to create this platform where anyone who wants to build on it should be able to do so. So I haven't looked at traditional medicine applications myself, but there's no reason why it couldn't be modeled using a platform like that.
Thank you so much for this talk. My name is Andres Diaz. I'm an MD PhD student from the University of Arizona. I've been coming to the summit for some time, and every time it's just awesome coming back to be here. I just have two quick questions. My first question revolves around diagnostics. We've discussed the role of prevention and also the role of increased access. But what I've seen in my experience a lot is diagnostics limiting what is already accessible. In pediatric cancer, methotrexate is staple drug for, especially for liquid malignancies. But methotrexate monitoring is critical for leucovorin administration. And in some low resource settings, without plasma MTX monitoring, you follow a schedule, and that schedule can lead to suboptimal dose of methotrexate, which leads to worse outcomes. So I was hoping if you guys could speak about the role of improving diagnostics to already leverage the tools and the drugs that are available in low resource settings. And then my second question was a more technical question about your model. We are working on an enzyme that leads to chromatin remodeling. It's called CDK5. It phosphorylates histones at certain locations, and that phosphorylation is leading to chromatin opening. But we're having difficulty doing ATAC-seq and cut-and-run sequencing to see what's being opened up and transcribed in pancreatic neuroendocrine and neuroblastoma. And I was wondering to what degree providing you with post-translational modifications on chromatin structures could lead to a model that could tell us what is being opened up through the model.
We need to talk more about that. Can't come up with an answer on the
Because
spot.
that epigenetic change is so physical.
Yeah.
There's a very like mechanical aspect to that.
Right, when you think of a model like this, breaking it down, think about there's a starting point, there's an ending point, and there's what happens in between. You can work with any of these. If we didn't have what happens in between an end point, and we only had a starting point, that is fine. We can model a cell with a chromatin in the starting structure and then determine what goes on. If you had the start and the end, we can use that as a differentiating variable and compute what happens to a cell where you are at the end. If we know what happens in between, we can model it. If we don't know, but you have guesses, we can model all of the different pathways and then let the simulation calculate probabilities and tell you what is possible in what scenario. So again, the simulation is not going to magically give you answers. It is going to help you manage the calculations that go into creating a simple solution from a complex set of variables.
So the more variables we provide, the better the model will be. Because
Exactly.
we have like interacting protein binding partners that we can give you. But after that, we don't know what's happening. So, anyways, thank you.
Does someone want to address the first part of the question?
I could talk a little bit about the diagnostic piece. I think that there's been a lot of discussion, particularly in Africa, about pathology and laboratory medicine, and how to develop those capacities. And there's been a lot of work that's gone on. USCAP and other groups have had initiatives that both train up individuals, pathologists and laboratory medicine experts, also histotechs, cytotechs, people that will support these activities because the number of pathologists in low research settings is so low. It's very difficult to bring up the number quickly, as we've seen. And in addition, there's a lot of opportunity and quite a few successes in telemedicine, telepathology, where images, pathology images can be rapidly read, and tumor boards, molecular tumor boards, and others can be brought up to help train people on the ground. So there's a lot of activity in that space, certainly not enough to address the question you raised, but it's certainly, we have good models for how it could happen if it could be brought to scale.
The other thing I just wanted to add to that, having treated a lot of leukemia patients in Africa, is that we take for granted all the supportive care that happens to support the toxicities, and the gains and outcomes have been because we've been able to intensify therapy with complementary improvement in supportive care. So that has to go together. So I think that's another really important aspect. You can go to the next question.
Hi, my name is Tim Xiao. I'm a consultant with a firm called Avanticor. Previously having experience working at USAID, NIH, and Astra. So I have a question for Dr. Kapadia. For the digital twin topic you mentioned, when we try to disseminate this beyond the US, then the medical imaging component regarding the international collection of medical imaging will have very different devices and different standards, different routine of annotation, etc. What would be a good way to harmonize those images to build a consistent digital twin? Secondly, as we know that quantum computing is along the line, maybe in the next 5 years or so, we might have a computable model right now. So aside from the molecular dynamics modeling for pharmaceutical compound you have already mentioned, what will be some other components that you think will be the first use case for quantum computing on the digital twin data? Thank you.
For the first part of the question, the images that we created, 10,000 CT scans, they were made using a certain scanner. So we had to build, Duke University has a project where they have built a virtual CT simulator that takes into account the manufacturer and what protocol you want to use, what sort of anti-scatter grid is in there. So these are, some of these simulations are extremely manufacturer specific. You could take this XCAT family and then scan them with 5 different manufacturers, wherever they are. You could use the specific protocols that are used in a rural hospital in Kenya versus a modern hospital in Congo or wherever else. The platform lets you do all of that. And your second question was about quantum computing. Quantum in biology and health is such a chicken and egg problem, right? There's a lot of promise, but we haven't been able to demonstrate that promise because we haven't had computing that can truly truly prove that application. Some things that I see possible is if you think of the whole field of quantum sensing, you can look at all of these effects in molecular dynamics, in biochemistry. They go through a series of interactions, many of which will have interim states that we have not been able to see or detect yet. If you couple quantum sensing with a pathway like that, combined with quantum computing, now you might be able to look at all of these interim states, which then might hold a key to treating a disease in a different way. We are no longer focusing on the start and the end point, but focusing on something in between that just breaks the pathway. That is my hope for it.
So I think we'll take 2 or 3 more questions before we break, so if there was additional questions.
Hi everyone, my name is Doris Kezia and I'm a first year PhD student in medical physics at Hopkins. And I'm originally from Cameroon. So my question is directed to you, Dr. Anuj. It's about the digital twin. So it's a really wonderful idea, but it also sounds like really expensive. So like how would, let's say my grandma in Cameroon, like how can she get access to this, and like how long is it going to take for this to like get back there now?
Absolutely, it is expensive right now. We don't have all of the capabilities. Fortunately, we have the computing, we have the funding and the resources to make this a reality. Like I said earlier, again, we cannot be unrealistic about this. I do not expect for a second that every single country, every single user is going to have the type of supercomputing facilities that have needed to make this a reality today. The goal is to bring in AI so that eventually this sort of model will run on your cell phone. Imagine if each of us would carry a digital twin of ourselves on our phones. You go to your doctor, you plug in your phone, and suddenly the doctor has the information you need, you're done with your visit, you take your phone out and you walk away. So these are ways in which you have to think about how to disseminate the technology in a way that is realistic. Even when you go to Cameroon, my grandma in India had a phone several years ago, which I wouldn't have imagined possible when I was growing up. So as these technologies develop, we keep an eye on how other things, other supporting technologies are also developing so that we can leverage them.
Maybe we'll take one last question. I know there's a lot more, but please.
That's why it's not a question. I was just going to address what she's just mentioned about Cameroon. That's why it's important that we see the heads of state. Maybe they can do it region by region. In the southern region, they have X number of machines there, then start region on a region, or 2 or 3 countries together, because we've got 55 countries on the continent. So they could most probably do like partnerships where we can see how we can lobby. So that's why the lobbying is very, very important. Because of course it's important, it's very expensive, so it's not every country that will be able to afford, because you've got some small countries that have only got a population of like 2 million, like Botswana and those countries. Then you've got the big giants like your big brother and sister, South Africa and Nigeria, that can most probably afford it. And then also to lobby with our billionaires, the big boys, let's go and lobby with those as well. So I'm happy to spearhead that initiative.
If I could just add one note about digital twins. The way you presented it, of course, is a goal of thinking about how it can be used in medical care and what, you know, the doctor will have that. I think one of the things we've been talking about in my field in epidemiology and genetics is to use it for research, which, you know, I think maybe was part of what you were saying, but, you know, they're using these novel technologies to improve the way we gain knowledge, generate knowledge about situations in diverse places in Africa, wherever it might be, will push forward what we have to use in maybe more traditional ways for prevention, early detection, or treatment. So there are a lot of different levels at which digital twins can be used, and I don't think that the only one is necessarily the doctor's office, which is a great dream, but there's a lot in between. Yes.
Yeah. All right, I think we'll take a break till 11, and then feel free, there'll be a lot of additional opportunities to ask questions. Thank you.